We're good to go. All right. Well, hello everybody. Welcome to another HRN Live. This is of course, the Home Rehab Network, also known as HRN, where we provide pulmonary and cardiac rehabilitation. We have Dr. Selsky, our cardiologist, that's on, and of course me, your friendly neighborhood respiratory therapist. Kind of like that Spider-Man thing. Friendly neighborhood Spider-Man. Anyways, we got some topics today. Now, Dr. Selsky, do you have some topics that you want to go over and address?
I'm totally flexible. I thought since you're into that lung stuff,
Do the lung
that we
thing?
could talk about hypoxemia, low oxygen levels, the effect on the lungs, and then the effect on the heart.
Oh,
Since you're
absolutely. I love it. Love it.
you're not.
So in a clinical setting, for those that do not know, but in a clinical setting, anytime we have PVCs or preventricular contractions, it's usually due to oxygen. Now, like lack of oxygen to the heart. Am I correct on that, Dr. Selsky?
I would say sometimes that's totally correct, but there are also many other causes
No, there are
of
other causes.
PVCs. So if we see 100 people with PVCs just randomly, PVCs are skip beats. So bump, bump, skip, bump, 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 skip. So that skip is called a PVC, premature ventricular contraction or beat. So yes, people with low oxygen levels, chronic lung problems very commonly have that, but there are a lot of other folks. People with sleep apnea, which again, it's from low oxygen, I guess, during the night, but even during daytime, they more frequently have PVCs. Anybody who has weakening of their heart, so what we call cardiomyopathy, where the strength of the heart's weak, those people have PVCs and skip beats all over the place. All over the
Gotcha.
place. People with blockages, people with other heart muscle problems. So it's not exclusive to low oxygen, but certainly very common in that setting.
Gotcha. Now, a lot of patients that go through that have some PVCs, especially like during exercise, or I guess they can occur any time. Is that would that be assumed correctly? They can kind of occur any time, but a lot of people think that they're also very life-threatening. As far as from the clinical settings and from our clinicals, we don't really see it as life-threatening because that's what is stated on our books. Could you elaborate on that, maybe?
Oh yeah, I'm happy to. If you were to put on a 24-hour monitor that will record every heartbeat for 24 hours. So in an average patient, there's roughly 100,000 heartbeats during the course of 24 hours or one day. So almost everyone has some PVCs, or these extra beats or skip beats for people that are joining us a couple minutes late. So everyone has some, but a small number in 24 hours might be a few hundred. A moderate number might be 2,000, 3,000, 4,000. But again, you're talking out of 100,000 beats. A few thousand would be a moderate number. And then a really large number would be as much as like 10,000 or more, which means like 10% of all the beats are PVCs or skip beats. So in those folks, bump, bump, skip, bump, bump, skip, bump, skip, bump, 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 skip. I mean, they're just having a slew of them. And your question was, can it occur at random times or anytime? Oh, absolutely. And on a monitor, we'll see people that have a cluster of hundreds and hundreds and hundreds over a few minutes, and then little or none for an hour or two, and then more and then less. So it can be off and on or intermittent. You can call it intermittent throughout the day. And the strange part is, I've always found this strange. If you do a heart monitor, and there's a lot of research on this, if you do a heart monitor on someone and in 24 hours you find 5,000 PVCs, that's a fairly large number, 5,000. Do another monitor on that person 3 or 4 or 5 days later, and you haven't changed anything. You haven't put them on any medicine. They haven't started anything new or different in their life. Same patient, 1 week later, instead of 5,000, they might have 1,000. So you can see dramatic differences day to day. That's why it's easy to fool yourself thinking, oh, they're gone, they're gone. We had hardly any today. Well, they may be back tomorrow. So it's off and on, off and on. Yeah.
Oh, wow.
But
Wow.
Alex, I was going to ask you about oxygen levels.
Yeah.
Since you're Mr. Oxygen, um,
Then you what?
the friendly neighborhood Mr. Oxygen.
Here all day.
I did want to get to in a few minutes some of the bigger effects of low oxygen aside from just PVCs. But maybe you could help us understand, how do you measure oxygen levels? And how do you define normal, or when do you worry that the oxygen level is low? And what might be causing that? Because you deal a lot with lung disease patients day in and day out. So, but
Well,
how do you measure it? How do you measure it, and how would you define normal, or where do you worry?
Well, that's an excellent question, and of course, I can use a lot of kind of medical lingo in a sense, but I'm going to try to, for our viewers, I'm going to try to make it a little easier to understand. But we look at first, when we look at oxygen, we first go with a non-invasive approach, and that would be, put a normal pulse oximeter. Now, the pulse oximeter assumes everything. It assumes you have the right amount of light, and it's not too much ambient light, not too much fingernail polish, temperature is correct. So we kind of tend to look at the dissociation curve. And all that means, roughly, is somebody with a higher temperature, the affinity attraction to oxygen on the hemoglobin cells will grab tight, really hold on tight to an oxygen molecule tighter. And when somebody is sick, they have a higher temperature. Let's say it's 102, 103 degrees. Well, their oxygen levels will look like it's 99%, or if not 100%, because the affinity attraction to oxygen is so high that the hemoglobin is not letting go. So a lot of people don't realize is that when you breathe in the oxygen. Well, that's just one action. Then the oxygen has to first you breathe in air, and then the oxygen has to get past your alveolar capillary membranes and then enter the blood, of course. Well, the problem that we see with high temperature, and there's a lot of problems with it, is if you ever see somebody, of course you would know this, but if any of our viewers or themselves have ever seen, if you ever had a high temperature and you looked at yourself in the mirror, what do you look like? You look pale. Sometimes you even have little signs of cyanosis. You have like bluing of the lips sometimes, depending on the severity. But your oxygen levels on your pulse ox shows like it's 100%.
I was going to answer that question differently. When you said, what do you see when you look in the mirror? I was going to say old.
I love it. Yeah, no, it's not the age, that. It's the mileage. No.
Yeah, right. Yeah, I got a lot of mileage.
No, so the oxygen levels, if the temperature is very high, no matter what, if the temperature is higher than a normal, and what is kind of considered normal? So a lot of people have a resting temperature, just any given day, that it's a little bit lower than our 98.6, 98.7. That's still considered abnormal, even though that's normal for that person. It's still considered abnormal. But if we see there's a low temperature on somebody or a high temperature, no matter what reading we read on a pulse oximeter, it's going to be erroneous. So we would have to do an arterial blood gas to really determine what the oxygen content is in the blood. So what we'll do is we'll just take a syringe, and it has some heparin in the very end of it, so it doesn't coagulate. So anyways, you insert the syringe in your radial artery, and you pull some blood out, and then you analyze it. And somebody with a very high temperature, they don't realize that, there's plenty of oxygen in the blood, but you're forgetting the oxygen in the blood is not being pulled out into the tissues. That's and then you will see somebody with a high temperature or even a low temperature. And for instance, somebody jumps into, you ever hear about those polar bear plunges? Where somebody jumps into the ice cold water? And if they stay in there for too long and they come out, if you ever see those on YouTube or something like that, if you ever see those, a lot of people that come out of there have like bluish lips. The lips are blue, they're having little, low oxygen, it looks like. And the reason behind that is because the oxygen molecules are being released too quickly. So the warmest areas in your body is actually the center core. So why does the oxygen just release there? There's no brain on a red blood cell, so it relies on temperatures and pressures. And a lot of people don't know that. But when we want to look at accurate oxygen content, arterial blood gas would be the most accurate. when we look at somebody with a pulse oximeter and let's say they have, Raynaud's disease, or they have poor circulation throughout their hands, and their hands tend to be really cold. Well, just because their hands are too cold could actually cause a wrongful reading on their blood oxygen. But one comfort thing, I will say, and as I digress, one comfort thing is when you breathe in oxygen and you measure with a pulse oximeter, are you really measuring what you brought into the body? Because if you look at a circulatory system, air comes in, goes into the blood. Does it go straight to your finger? No. The first place it goes to is your heart. And then it goes to your brain, your liver, into augmentary system, lymphatic system, nervous system, everything, right? And what you're measuring on an extremity is what is left over. So did the brain, like if you put a pulse oximeter on and it shows 80%, did the brain get 80%? Did the heart get 80%? No. It was oxygen is readily being pulled out, and as oxygen gets pulled in, lactic acid builds up if it's in a muscle, and then of course CO2 is produced. So the more oxygen an organ consumes, the more CO2 is released. But the first assessment No, go right ahead. Sorry, I didn't mean to keep going.
Oh, no, I didn't mean it that way either. I feel like I'm in a class, though. I have a question.
No, please go right ahead.
From a practical standpoint, so not somebody that's cold, not somebody that's hot. They have a pulse oximeter that works. They don't have fingernail polish on. Okay. And they're not feeling well. They're short of breath or whatever they're having. What levels are normal? When do you start to worry? When should someone think about going to the emergency room for those kinds of? Give me your feedback, not on the polar plunge, but just somebody in their family room not feeling well, short of breath. What numbers are good? What numbers are horrible?
All right, so let's look at the work of breathing. According to the American Chest Physician Guidelines, work of breathing is not really caused or contributed to the symptoms of out of breath. Sorry, one second. My camera. I'm sorry, guys.
Were you trying to sing?
No, it was. I accidentally pressed the button. It was.
I thought you were
my
singing.
fault.
I thought you were singing for us.
Hi, Sherry. You just got home from pulmonary rehab. Fantastic. So to answer your question, a lot of people think that when they have a higher work of breathing, it's due to not enough oxygen. That is not correct. It's actually CO2 that produces the symptom of feeling out of breath or an increased work of breathing. So a lot of people, what they'll do is bump up their oxygen thinking that, oh, that's going to help me. But if I bump up my oxygen too much, well, the body regulates that inside the body, of course. The body regulates that, and if it's too much oxygen, it will try to slow down the supply. And what that means is that it will slow down the heart a little bit. And of course, it'll make us feel, it'll make us feel better in a sense. But that's not necessarily, a good thing, because when we look at absorption at atelectasis, when you flush in too much oxygen, especially higher than 50% fraction of inspired oxygen, that's what we call FiO2. We go to the possibility of lungs collapsing. And that's an actual term, absorption atelectasis. When you flush out the nitrogen, because you're putting in too much oxygen, and the nitrogen supplies pressure, and all it's going to do is just flush the nitrogen out, and of course the lungs will start shrinking and collapsing. So work of breathing is not really contributed to low oxygen. It's more contributed to CO2. So another good way of looking at how high CO2 is, and this is not for each and every person, but this is a normal sense. When somebody's in pulmonary rehab and I see an increased work of breathing, I tell the person to breathe in just a little bit deeper, because they're struggling to breathe super fast with a very shallow breath, and they're not pulling it. The body needs a gallon of oxygen, but they're only bringing in like a tablespoon. It's just not enough. So you have your heart rate increasing because of the CO2 buildup, and your body's trying to circulate that CO2 to your lungs so you can breathe it out, but you're only breathing out shallow. So needless to say, when somebody's working out and they feel out of breath, it's not necessarily contributed to oxygen, it's actually contributed to CO2. So that's a ventilation issue. When I see somebody, if somebody's raising their hand and saying, hey, I'm feeling out of breath, I will just have them do a talk test, a simple talk test. If they can say 3 or more words, they're good. But if they can't, and they're struggling to breathe, like they're saying this, my breathing is manageable. You know, they're saying 1 word every time they have to initiate a breath, and that's the max they could say. That means the work of breathing is way too high. So when somebody's wondering if their oxygen is too low, I look at how they're presenting themselves. First, if they have very low oxygen, like very low oxygen, well, how would their balance be?
How low are you calling very low? That's what part of my question was.
It's a tough question. It's a very tough question because it depends on how severe of an exercise is. When I was in the Olympics, I didn't train in the Olympics. I trained with exercise physicists, and I was there for about a month and a half. And there was these major athletes just running, doing their thing, and they're trying to break world records. And I saw their oxygen levels because they had a monitor on these guys. I saw their oxygen went down to 74%. And I looked to the sideline, and they said that's normal. I said, but I thought it was supposed to stay above 90. And he says, no, at rest, yes, but not during exercise. So during exercise, it's normal for oxygen to drop down for a little bit, but in a matter of about 30 to 40 seconds, it should come right back up. You have to wait for the heart rate to increase. Now, let's say you have a patient that's on a beta blocker that prevents their heart rate from increasing. Then, of course, they're going to have a lot of problems exercising because the heart's not, speeding up as fast as they would like for CO2 to be circulated so they can breathe it out. They just keep retaining it, so...
I guess I was thinking more at rest rather than exercise, Alex. So if someone's just sitting in their family room not feeling well, what kind of numbers are bad, or what should people do about that?
Okay.
So I think your one point was really good. Can they talk? How do they feel? But what about the numbers? What numbers are worrisome? Or
anytime it's below 88, it's worrisome. But there are some people that their normal oxygen sats that are determined by their pulmonologist, that their normal is 85. And we have people like that their normal oxygen level is 85. They're not going to die, their oxygen levels are 85. If somebody like that walked into the hospital with, with an exacerbation or something, or they just went into the hospital for some other reason, and they check their oxygen, and they see 85, they're most likely going to put them on oxygen. They're also most likely going to try to find out why. If the hospital has their medical records, they'll see that the doctor noted that their normal resting oxygen is 85 or something. Then that's that person's normal. But as for anybody, I like anything above 92. So if somebody is sitting at 100%, I'm actually going to worry about them. Because if somebody's sitting at 100% oxygen, I'm probably going to worry quite a bit, because that means at the last end of sight, nothing was barely pulled out. Like no oxygen was pulled out. It's 100% saturated. If 100% comes in and 100% is left over, how much did the body consume? So that's what I'm worried about. Are they breathing in too much oxygen, or are their lungs just super good? Or maybe they have a high temperature. Maybe there's a medication or something that's causing this problem, But for anybody, anything at rest, anything above 92 is okay. Anything above 95 is really good. And that's the rule of thumb.
Okay.
How about that?
Wonderful. Wonderful.
Oh, and if anybody has anything, any questions, you just got your Delta V today. Good, very good, Sherry. If anybody has questions, please write in the comment section. We'll be happy to address those. Any questions you want. We have a cardiologist, and of course, I'm a respiratory therapist. So if you have questions, please write in the comment section. We'll be happy to address those.
One thing I was going to mention, just because we're on the topic of oxygen, and you're the lung person, I'm the heart person. Mm-hmm. A full-fledged heart attack. Somebody goes to the emergency room, they get EKGs done, they get blood work done, they say, oh, you're having a heart attack. Well, it turns out there are lots of different types of heart attacks.
Uh-huh.
So in the cardiology world, believe it or not, the experts have lumped these into 5 different groups. And we don't have to get into all 5 because it gets kind of complicated. But the average or typical heart attack of someone coming in with chest pain, EKG, they rush you in, they talk about putting in a balloon or stent. The typical heart attack is from atherosclerosis, which is plaque building up in your arteries, and the plaque cracks inside the artery on the heart, and you get a blood clot. So the great majority of heart attacks are from plaque building up, cholesterol building up, it cracks, and a blood clot. And that's called type 1 heart attacks. But type 2, the reason I'm mentioning this, type 2 heart attacks are from what we call a mismatch.
Oh.
Mismatch. So either not enough blood coming into the heart or too much demand on the heart. So you're tipping the scale, and more frequently it's not enough blood coming into the heart or oxygen coming into the heart. So one of the more common causes of a type 2 heart attack would be somebody with severely reduced oxygen levels. So either a terrible exacerbation of their COPD, they come in, they're wheezing, they can't breathe, they can hardly talk, they're being considered for going on a ventilator because they're just not keeping up, even with aggressive measures with nebulizers. You know, a lot of people have been through that. But the oxygen level is so low, maybe in the 60s or 70% saturation, that it actually puts a strain on the heart and can cause a little type 2, a little heart attack. But again, that's not what most heart attacks are from. As I just said, most are type 1, where there's plaque and the plaque cracks and the person wakes up at 3 in the morning, there's an elephant on the chest. Those are their typical type 1s. But type 2 very commonly can be from a low oxygen level. There certainly are other causes, severe anemia, where the person's red blood cells are not adequate. They've had rectal bleeding and their red blood cell count is low. Well, the red blood cells carry oxygen. So again, that can be a type 2 heart attack. In some people who have crazy fast heart rhythm problems, like atrial fibrillation, and it's going 150, 170, 180, their heart's going so fast that it outstrips the oxygen coming in because the demand is so high. So again, it's that mismatch, either too much demand or not enough supply. But in the COPD world, people coming in with crazy low oxygen levels can trigger a type 2 heart attack. I just thought it's interesting. But again, that's not your average heart attack.
Right. But speaking of heart attack, when I was doing my clinical rounds, we were always taught by paramedics and on CPR. And let me just kind of explain what this guy here. Oh, by the way, don't ever pull somebody by the groin. All right, let me just pull this down. So, let's say we have somebody that's suffering through a heart attack. So, what I saw was something very interesting, and it was just an emergency physician. I'm not trying to say just, but it was an emergency physician, and there was an older, very elder lady. I would probably say around 80s, maybe a little bit higher, maybe close to 90. But when they're doing chest compressions, this person was going super fast. And usually, you go with the rhythm, staying alive, like, and you have to go 2 inches in. And for the people that don't know, when somebody's doing chest compressions, you're giving about a 30% cardiac output, if I recall from my notes. When you're doing chest compressions and you're doing well, you're giving about a 30% cardiac output, so you have to go a little faster. Well, this doctor was going like this, like very quick, and the person came back like super fast. And I was trying to ask the doctor, but unfortunately the doctor was too busy. But I was trying to ask the doctor, why would you go so quickly? Could you elaborate on any reasons why somebody would go fast? Because it looked like it worked just fine.
Well,
Like when we're doing.
the specific protocol for CPR. So for the either healthcare providers or for the public,
Mhm.
it's called BLS, Basic Life Support. So every couple years they revise the numbers. You know, is it one person CPR, two-person CPR? I personally think everyone in the whole world should learn to do CPR. I mean, it costs, you know, 40, 50, $70 to go to a course. You can do it online, you can do it, you know, live. It's available all over the place. But you really could save a family member's life. I mean, I can't say that enough. You could save a family member's life or some innocent bystander. You're on the street corner waiting to cross the street, somebody collapses. You just never know when somebody's going to collapse.
Right,
But
right.
when you participate in BLS, Basic Life Support, you're actually trained on the latest, greatest numbers. So um, again, I wasn't there to see how fast this emergency room doctor is going, but there are numbers. It's usually 80 to 100 compressions per minute, but no one sits and times it. So
Right, right.
I've been in many scenarios where we're resuscitating someone. Usually at the hospital, it's a cardiologist or sometimes it's even a cardiologist in training at a teaching hospital where they're actually running the code team, directing everyone how to do it, you know, and we'd be putting in the tube down the person's throat to put them on a ventilator. Someone else is doing CPR. Someone's getting an IV put in the neck. So, you know, I was in charge of many resuscitation efforts, but I got to say, it's a very heightened scenario. Unless you're really experienced and you've been doing it for years, everybody gets worked up. Oh, come on, somebody's dying in front of you.
Right.
So the anxiety level of the participants is usually very high. I mean, it's like, okay, come on, let's go, let's go. You know, you want to help the person as much as you can. So I think as far as the CPR rate, Alex, again, I wasn't there. I'm just going to guess that person was probably nervous.
Oh,
You know what I'm
okay,
saying?
okay.
It's like, oh
Yeah.
gosh, let's go, let's go. You know, they're hyped up, they're nervous, or you know, trying to give it their all. The other thing that happens all the time when you do CPR is fatigue. The person doing the chest compressions, it's hard work, physically
Oh, yeah.
hard work. So after a few minutes of doing the chest compression, because some people we're doing CPR for 30 minutes or more, and if they haven't come back around that time frame, they're probably not going to survive. But even 10 minutes of pumping on someone's chest is exhausting, and that person has to speak up. And usually you can tell that they're getting fatigued because they might have started off going fast,
They
and
start
then
slowing down.
a couple minutes later, they're going a little slower, and a couple minutes later, it's like, okay, time for somebody else to take over. Because if they're getting tired, the person who needs resuscitating has got to have somebody strong to come in, and so people take turns. It's like, okay, your turn to do it now. So
All right, let's say
but
let's say this. We have a person at home, and there's two people. Let's say there's an in-living assistant and a patient. And a patient notices, or the GNA or CNA or a nurse notice that the blood pressure is very low on person, and the person's fainting. The first rule of thumb, from what I recall, is you elevate the legs up, try to draw the blood back down to get more pressure. And you know, a lot of people, when they feel fainting, the first thing that, of course, they want to do is call 911, and that should be your first go-to. But I would think the first go-to is elevating the feet first. You know, that's what I would think, is help the patient first, get them to be, you know, get them a little bit more controlled. But then, of course, if there's somebody else available, or maybe while you're doing all this, have 911 on the phone, of course, and call 911 as soon as you can. But with plaque buildup, what is the plaque usually build up by? You're mentioning on plaque buildup in the heart. Is that usually like saturated, you know, or like what causes the plaque buildup usually?
yeah, let me hit on the first question and then the second one.
Okay.
Um,
Sorry, I didn't mean
so
to put
the
too many
first one,
questions out there.
no, I'm just trying to, I didn't want to forget something. So the first one you mentioned was somebody fainting or their blood pressure is low, they feel like they're about to faint. and you mentioned putting the legs up. I think the single first thing to do is to assume a safe position.
Okay.
Safe position. So if you're near stairwell or stairs or set of stairs, you're at the top of the stairs and you feel like you're going to faint, oh, get away from the stairs. Because if you faint and you roll down the stairs, it's all over. You're going to break your neck. Same thing if you're out near a curb or traffic and cars and you're feeling, oh boy, I really feel lightheaded, like I could faint or black out. Get away from the car. See what I'm saying? If you're near a bathtub, let's say you're in the bathroom, near the bathtub. So usually the safest, best position is to lie down on the floor. I don't know where it ever came from. People think just put your head down. Well, if you're in a chair and you just put your head down, you're going to tumble off the chair if you pass out. So usually the best place, I always say, is lie down on your back and put your legs up. So putting your legs up will help more blood return back to the heart, but better to lie down on the ground, as long as it's a safe place to lie down.
And that's why you're the doctor. Heck yes. Oh yeah. Did you ever see those drones that fly out and they actually do chest compressions for you? You ever see that?
I have not seen. No,
that
I
is
have
the
not even.
craziest thing. They also, like, paramedics have a machine it's a vest that you put on the person and it automatically does chest compressions so that fatigue is not there. But they also had a drone.
That I've seen. Yeah.
You've seen that one?
I've seen the vest device, although it's not widely available. So I think that was years ago. They were hoping that would catch on. I only saw that a couple times. I have never even heard of a drone coming in to see. Now, one would hope that the drone went to the right person. Right. Imagine walking down the street with your dog and all. You're walking down the street with your dog, and all of a sudden a drone comes.
Oh, that would be horrible. You know, a lot of people don't know that. When somebody does chest compressions, the chances of breaking ribs are all the way up to very, very, very high. So, yeah, paramedics said that if you're not breaking ribs, you're not doing good chest compressions. And I kind of keep that as a rule of thumb, as that's going to be kind of normal to break ribs, But because you're going, not from, of course we don't, if you ever done a basic BLS, like chest compressions, if you haven't done so, there are a lot of good resources out there, but I would specifically go to, where would you think you would go to? Like the firehouse? If somebody wanted to learn about CPR, what would the best place to learn it from, you think?
Oh, go online, the American Heart Association.
That is probably
American Heart Association, and they have resources. They have lists. You can actually put in this day and age on the internet, you can actually put in your zip code, and it will show the centers. If you want to do it live, it will actually show the centers in your vicinity of where you can sign up for a course. And you sign up, you can pay online, and you just show up. It could be at a church, it could be at a hospital. So it's really super easy to find a place now.
Oh, that's wonderful.
And I would really recommend it for everybody. I mean, it's a few hours of your time to save somebody's life.
Oh, absolutely.
Getting to the other topic, you were shifting to, because we had mentioned heart attacks before. Plaque. What is plaque? So there is that word plaque that goes on your teeth. That's different. So I'm not saying dental health doesn't have anything to do with the heart. There probably is a link of some sort, but that's more inflammation. But plaque on the teeth is tartar, and that's different. So plaque inside of an artery is greasy, fatty material. So who gets plaque? Certainly if there's more plaque in your bloodstream floating around, then more likely for it to build up. So yes, eating a lot of saturated fat, donuts and things with butter, and oh my goodness, there's a long list. So saturated fat is terrible. Unsaturated fat is much, much better. So anytime you go to a grocery store, you ought to be looking on the label, turn it around to the back and look. So if you're seeing saturated fat of a few grams or more per serving, well, that's really high. I mean, I try to shoot for 0 of the saturated fat. 0. But it's not just a cholesterol level. Smokers get more plaque. Oh, any kind of tobacco exposure. Vaping, cigarette smoke, pipe smoke, cigar smoke, secondhand smoke,
Did everyone
any
hear
tobacco.
that? Make sure everyone's
Oh
listening
my,
very carefully.
oh my, including vaping. It's a tobacco product. It is. Vaping is a tobacco product. So tobacco exposure increases plaque buildup. Genetics increase plaque buildup. You know, your father had a heart attack. Your uncle had a stent. Your sister, who's only 48 years old, already had an aneurysm and balloons in her legs because of plaque and blockage. So sometimes it's familial. Diabetics, oh my goodness, diabetics all the time get plaque buildup. And the longer you've had the diabetes and the worse the control, meaning people are running A1Cs of 10, 11, and 12, really crazy high numbers, more and more plaque. People with high blood pressure get more plaque. So if one were to, I don't want to sound crude, do an autopsy on someone who has deceased or died or passed away, and you actually open the chest, you go down to the heart, and you were to cut open one of the arteries on the heart to look at it and send it under a microscope, you'll see greasy, fatty material. So it is cholesterol-like material, but it's not just from a cholesterol level. It's all these things I mentioned, this lifestyle, the genetics, the smoking, the diabetes, the blood pressure, the cholesterol level. It's all of that. And to be honest with you, it's probably things we haven't even figured out yet. But those are the things that are established that cause more plaque. So less plaque is better.
Very interesting and very knowledgeable, extremely very knowledgeable. That's one thing I like doing, is learning from very knowledgeable people. But you have quite a bit of experience.
As soon as I see one walk by, I'll let you know.
Yeah, but like you definitely, I'm sure you have seen quite a bit in your life, as far as from as being a doctor, but being a cardiologist, you've seen quite a bit.
Sometimes I've seen things I wish I hadn't seen.
Yeah, I can.
We won't go there.
Yeah, no. But I can definitely understand that, and definitely respect that too. But with cardiac, let's say if somebody had a myocardial infarction and they want to get rehabilitated through cardiac, will their heart improve? And what's the usual improvement that you would see from somebody trying to exercise and maintain and becoming more healthy in their lifestyle? What's the usual rate of time, or is it permanent?
It's a great question, but it's a complicated answer. So anybody with a heart attack, anybody. So it could be a type 1 heart attack, a type 2, it could be a big heart attack, a little heart attack. It could be somebody that had a stent or bypass surgery, or somebody that just, didn't even have a catheterization, and they're just recommending medications. Once they recover enough to get out of the hospital, all of those people are candidates for cardiac rehab, because cardiac rehab is a 3-month program, 3 times a week, where people exercise under supervision, and they're taught about cholesterol and the Mediterranean diet, and they're taught about blood pressure and how to exercise properly, and A1C levels and blood pressure readings. So it's an educational process plus exercise. So people do get better. Most people get better. But it's been studied, and certain things get better in almost everybody, and certain things, it's variable, depends on the patient. So most patients, their blood pressure improves with rehab, their cholesterol levels improve, they lose weight, because we're getting people to eat better and exercise more. So, and people feel better. So their stamina, their stamina level, their functional ability, what they can do, how much they can walk and go up steps and carry groceries, and all those things get better in most people. Will their heart actually get better is a little trickier question. Little trickier. So people will feel better. People live longer by going through rehab. There's a less chance of having to get hospitalized again. All these things have been researched. But does the person's heart muscle actually recover more, it depends on a lot of different things. So I'll give you just a quick example or two,
Sure.
although I'm never quick. I'm never quick. I always talk too much.
Oh, I did the same, but we're fine. That's who we are.
So I'll give you two scenarios. So somebody who's very vigilant with their health care, they're on top of things, they jump on things, it's their personality or their chemistry. And they just happen to live 2 or 3 minutes away from the hospital. And they wake up at, they wake up at midnight. They've only been in bed a couple hours and they're having this crushing elephant on their chest. And they rush to the hospital, right? So it just started. They rushed in. They didn't dawdle. They didn't look on the internet. Am I having a heart attack? They rushed into the hospital. And they were only a couple minutes from the hospital. And as soon as they get there, the emergency room team, they do an EKG. They say, oh, gosh, you're having a heart attack. And they call in the big catheterization team, and they rush in and they do the catheterization. And literally within 30 minutes, there's a stent in that person's artery. When they go home, there's usually almost no detectable damage to that person's heart because they acted quickly. It's like, how can I give you here's a great example. If you go away on vacation and your house plant has had 0 water for 2 weeks,
In there.
that house plant, when you come back, is going to be crunchy and dead, right?
Right.
So things need oxygen and plants need water, but the human body, you need blood and oxygen. So every minute matters when you're interrupting blood flow. So with a heart attack, if you're at that emergency room in 20 minutes, 30 minutes, and they call in the team, and 20 minutes later, they're getting that stent in there, you've saved that person's heart. There's usually next to 0 damage. So they're still good candidates for rehab, but those people are like nothing ever happened. I'll give you one other scenario. And again, these are extremes. These are both opposite ends of the spectrum. Here, somebody woke up at midnight having chest pain. I'll make it a man because a lot of men are stubborn. Sorry. So some gentleman wakes up at midnight and he doesn't want to worry his wife. So he doesn't wake her up, and he's having this elephant on the chest. So he goes down to the kitchen, he sits with the dog for a little bit. Then he looks on the internet. Why am I having chest pain? Is this really a heart attack? I've never had a heart attack. So he still sticks it out and waits. Then he tries to lie down on the sofa and he can't. And then like the next morning at 7 a.m., the wife comes down. What are you doing down here? He says, well, I'm still feeling a little chest pain. I've had it since midnight. Oh, you're going to go to the hospital. And he argues about it. Well, finally, he goes in at 9 a.m., right? 9 hours after the start of the heart attack. Not like the guy that was, 2 minutes away. So when they get to the emergency room, they rush in, they look, the artery's closed, they put in a stent. Well, there was no blood flow for 9 hours. That person had a big heart attack. So there was a lot of damage to that person's heart. They're also great candidates for cardiac rehab, but they're not going to get the same recovery that person did who had a lot of damage. So sometimes when you wait too long, damage is permanent. That person may still get better, but not like the person that rushed in. Does that make sense?
Oh, that definitely makes sense. That makes a lot of sense. I see a lot of people in pulmonary rehab, they try to not go into pulmonary rehab, so they'll just try to join a gym thinking it's the same exact thing. And it's not even close. You want to be monitored. There is a lot of involvement from doctors, clinicians, nurses, respiratory. There is a lot of involvement, and a lot of people don't know that. What would you say to a person that asked you, as a doctor, and let's say it was one of your patients, and you suggested cardiac rehab, but the patient's saying, "But I'd rather just go to my gym." What would you say? Like, what could potentially, complicate things if there is complications, which I would think there would be, but what would complicate things as far as that, or like would that be like I completely understand people trying to get healthier, but when they have a heart attack and that word heart attacks just strikes fear amongst everybody, a lot of, not everybody, but a lot of people would try to just go to the gym and try to see if they can strengthen up the heart. But we saw some data on pulmonary that people try to do that, and the success rate off of YouTube. No offense to YouTube, by the way, because we're on YouTube. But a lot of people on there weren't clinicians, and they were trying to give advice to other people, and it was actually making their symptoms worse. Like there was one person saying, "Oh, inhale hydrogen peroxide," or eat more of this. Here's a new pill that will fix all your problems and take away all your heart, all the damages from your heart attack, and that they'll try to go that direction, and the results are very, very horrible. But if you have somebody who wants to just join a gym and not go into cardiac rehab, what would you say to that person, Dr. Selsky?
Yeah. Well, to me, Alex, and I agree with you 1,000%. To me, the bigger the problem that the person had, the more they ought to get professional help. So COPD, come on, COPD is a terrible problem. It's terrible. I mean, so it's not a cure unless maybe you get a lung transplant or something, big. But for most people, they have to live with it. There are treatments for it. You can help that person dramatically, but they have to live with it. So heart disease, oh my goodness, a heart attack, roughly a third of people die. So a heart attack is a huge problem. They should be scared. And to be quite frank, the best time to reinforce the need for getting appropriate help is when that person feels scared or vulnerable, because then they're willing to say, "Oh, you know what? I love my beef and gravy and my potatoes with cheese and sour cream, but you know what? I could have died. I've got to make these changes." Whereas if you wait and a month later, the person's going to the gym on their own, they say, "You know what? I'm starting to feel all right. I'm gonna go back to smoking a little. I sure do love that the meatballs and gravy." I'm like, so to me, it's an opportunity to change that person's life and keep them from having another event down the road. So I think it's a huge mistake to just go to the gym. You're not going to be supervised. You're not going to know, are you exercising enough or too much? You're not going to know the proper type of exercise, but you're going to miss all the educational part. And that's, I think, even the most important part. How to eat right, how to read labels, how to look at saturated fat, how to know where should you be checking your blood pressure, how often, where should the readings be? All that stuff, you're not going to learn that at the gym from the guy next to you on the treadmill. So I think anybody that had a heart attack, it's a huge mistake to not go into rehab. And I'm not saying that because I'm involved in rehab. That is from my heart. I truly believe that. Huge mistake not to. And I think more doctors should be pushing patients. I mean, it was always an issue when I was in practice for years. How much do you push someone when you know it's good for them? So some doctors push people a lot. Some people are like, "Well, why don't you think about it, Joe? Let me know if you want to do it." Well, they're not pushing at all. So part of that's the doctor's chemistry and how well they know the patient, but I think it's wrong for the cardiologist to say to the patient, "Well, you could do rehab. If you want to do it, just call us." I'm like, wow, that's not an endorsement. It ought to be endorsed as something of huge benefit, because it is. It's been proven in research.
Absolutely. That's fantastic. Sherry, thank you. Sherry says, "Love you guys. Keep on teaching us." I love it. But
love you too, Sherry. Love you too, Sherry. I don't even know Sherry, but I love you too, Sherry.
But if anybody has questions, we're wrapping up right now. We only have a few minutes left. If you have questions, please write in the comment section. We'll be happy to address those. You can come up with any types of questions you have. Any questions that, it can be from heart, it can be from lungs, whatever you guys want. But you're very welcome, Sherry. You're very welcome. Does anybody else want to talk on the topic a little bit? I see a lot of people on Facebook on here. So, of course, we have our cardiac rehabilitation program, and Dr. Selsky runs that cardiac department. And, of course, we do both, pulmonary and cardiac. A lot of people that usually have COPD usually also have some type of heart complications, usually. And that's what we usually see. It can be from, it could, I think there's a plethora of a list but it could be all sorts of, congestive heart failure. It could be, circulation perfusion issues. It could be, just there's a whole long list of reasons. But if you're unsure, I would think that the first thing you want to do is, if you're unsure, is just let us know. Just let us know. It's like, hey, I had a heart attack, or I think I have some heart complications. If you're not sure, we'll give you a best suggestion, but the very first thing is obviously going to that doctor. Just letting that doctor know. Oh, Diane asked, did you find out if it is benefit to use THC gummies for COPD? The research that so Diane, to answer your question from last time, I did some of the research, but there was not a lot of research on it. There wasn't a lot of investigative. There wasn't a lot of peer review on that. So the information there isn't concrete, and the information there it's not necessarily an improvement, but it's more of a, I don't want to say psychosocial type of thing, but it's there's not a lot of information is what I'm trying to get at. So there's not a lot of information. So I can't say it's a good thing or a bad thing yet. I hope you understand it. I have to go off of notes, and I have to go off of proven, like studies, proven studies that show whether or not if it does help or not. Some people do get a placebo effect where they feel like something is working, but it's actually not. They just kind of have a euphoria of a feeling. I have panic and anxiety, so often feel like heart problems, have mild COPD. How do you know when it is a problem with your heart, etc., versus anxiety? Dr. Selsky, how would you answer that one? Is it I have panic and anxiety attacks, feels like heart problems, have mild COPD, and how would you know when it's a problem with your heart, etc., versus anxiety? It's a tough question. I'm not sure how to answer that one. Dr. Selsky, were you muted? I'm sorry. No. I see your lips moving, but I don't want to hear anything.
How about now?
Yes.
Still? Okay. Yeah, no, that's a common question, and it's something that comes up a lot because mental health issues are very real. And finally, after decades of people being embarrassed about it, there's nothing to be embarrassed about. It's a health problem. So anxiety, depression are very, very real and should be addressed openly with your doctor and discussed. So now that I think it's acceptable in more circles and more people, anxiety is huge. It's amazing how many people struggle with anxiety. I think most people do. So what happens when you get anxious? It makes your heart race. People feel palpitations. They start to breathe faster. They get lightheaded sometimes. And an extreme level of that would be what we call a panic attack. So oh my gosh, oh my gosh, so they want to get up and run or flee or leave the scene or get up and walk fast and leave. So it's very real. But when a person feels their heart racing or pounding and their pulse is fast, how can you tell if it's strictly panic attack or is it your heart causing it? So it's a tough call. If you were to measure your heart rate, like with a pulse ox, let's say you have a pulse ox and you put it on, normal heart rate's up to 100. So with a panic attack, it wouldn't be unusual for somebody's heart rate to be 110, 120, which is a little fast. Let's say you did a pulse ox and your heart rate was 190. Well, that's a crazy fast heart rate. That's not going to be just anxiety or a panic attack. That's going to be a heart rhythm abnormality. And we see some people coming in with their heart rate 220, 230. I've seen 280.
Wow.
So if your heart's going that fast, you're going to feel lightheaded. You're going to feel like you can't breathe. You're going to feel your heart going crazy, crazy, crazy fast. So it's not like sitting at home, you can really decipher that. But if you're having a panic attack and your heart rate's 100,
the chances are that's not a heart rhythm problem because 100 is really not very fast. But to settle the question, to settle the score, so to speak,
Yeah.
the key would be to catch it on a heart monitor. So you could do it on an Apple Watch, maybe if you have a good Apple Watch and it picks it up, or a Garmin or Fitbit. You could do it on one of those, it's called Cardio Mobile, where it's got two little silver pads and you put your fingers down. You can purchase one of those for under $100 and it records your heart rhythm. Or you go to a cardiologist and they'll put on a heart monitor, like a patch, a big patch. It's like a large Band-Aid, and it records your heart rhythm. And you can do that for 2 days or 3 days or a week. And it actually will show the cardiologist the heart rhythm. So the tough part in that is if people only have an episode once a month of this panic attack versus their heart racing, it can be a little tough to catch if it's 30 days apart. But that's the answer there. So the faster it is, the more I'd worry it's your heart. And if you really are having recurring spells where your heart's racing, better to get a heart monitor put on and figure it out.
Absolutely.
And it might be anxiety, but that's the last diagnosis you want to just assume. You don't want to miss a heart problem if it is a heart problem.
Right, right. Amber Klein asks, is it best to take lorazepam in the morning or evening? I don't know how to answer that.
Well, lorazepam is Ativan. So it's like Valium. Lorazepam is like Valium. So it's a sedative tranquilizer category. It has some addictive potential. So, the average patient doesn't take Ativan every single day. I've had patients who they have to. Their doctor prescribes it. They feel like they need it. Although there are other drugs that are less addicting that might also help anxiety or that type of problem. So is it better morning or night? It's a long-acting medication. It lasts for hours and hours. I think you'd have to look at when is your anxiety real bad. I don't prescribe drugs like that being a cardiologist, but I would think if the person's struggling with a lot of anxiety during daytime hours, it might be better to take during the day, but it's going to make you sleepy. There's no, that type of drug, it's like Valium. It's going to make you tired or a little groggy.
Gotcha.
That's why some people take it at night, but that's not usually the first drug of choice for sleep disorders.
Right.
Primarily due to its addictive potential.
Okay. Well, guys, no, go right ahead.
No, that's good.
Well, everybody, that is, it's 12 o'clock, and it looks like it's 12:03. If I'm, actually, I have it on my watch right now. 12:03. All right, it's 12:03, so we're going to go ahead and say goodbye. We'll see you guys later. If you have any comments or anything further as you're watching this on a repeat, please add them on the comment section, and we'll be looking at those and see if there's any types of topics you want us to address for next time. And that is it. Thank you very much, Dr. Selsky, and thank you very much, everybody. And we'll see you all later. Okay.
Thanks for watching.
Thanks a lot. See you guys. Bye-bye.